School of Public Health and Cancer Center. We're going to get started in just a little bit. So just stick with registration going. And if you don't mind, please entering your name, your organization, your title, and anything that you really want to know more about today or you're hoping that we'll address, that would be great as well. And we'll try to make sure that we get to all those topics today. So we'll give just maybe another 30 seconds for folks to jump in. We're just a couple minutes after the bottom of the hour. Wesley, anything you want to share with people around AB or anything as we get started?
So everyone is muted when they come in. We ask that while the speakers are speaking, if you have questions that come up, put them in the chat. We'll have time for maybe 1 or 2 questions at the end of each session, and then a little bit more time for Q&A at the end. And then, yeah, I'm recording this, so we'll have it available on the CCSP website after the fact, and we'll share any slides that the speakers have as well. Yeah, Elsa, anything else to add logistics-wise?
It should be good.
Okay, awesome.
All right, we're going to go ahead and kick it off, everybody. So thank you so much for joining today. We will be hosting our annual CCSP meeting at actually June 9th, but we did think it was actually helpful for us to go ahead and launch and discuss a couple of the big initiatives that we're working on through the Colorado Cancer Screening Program with funding from our CCPD grants program. And I know we have several of our grant folks on from the health department, many of you from our clinic systems, many partner organizations. So super excited to have everyone on. We're excited that we're refunded for the next 3-year cycle as well. So we'll be talking a little bit about that in our upcoming meetings. But today we're really going to focus on what are the areas that we really can work for implementation of preventive cancer screening with the focus of colorectal, lung, as well as hereditary cancer. So I'm excited to have panelists who are well known throughout the country, some hailing from our own state as well, to talk a little bit about what's going on and how we really can be thinking about the implementation and making impact within our communities, which is what CCSP is really about. I'd like to say a huge thank you to Elsa Welpsing, who has been my partner in crime with this initiative for several years, helping really keep the boat afloat as we implement one of the largest cancer preventive screening navigation programs in the country, and also Wesley Lighthall, who's also new-ish to the team, but who's really helping manage a lot of the navigation work too. So thank you so much. Today, we're really going to be featuring also, again, some key expert in the field. Erin Darbuz from Fight Colorectal Cancer is going to be sharing a lot of the policy wins related to colorectal and rectal cancer. And I know for our navigators, those who are implementing our programs in primary care, there's a lot of great work that's been done around access. And I really am excited that Erin can talk about some of those policy legislative wins and where we have some opportunity. We're also going to be hearing from Nick Torres from the American Lung Association. And Nick is relatively new to the team and working with us. So Nick, we're really excited to hear, particularly at the Colorado level, what's going on with some of the policy related initiatives. And then also hearing from Heather Cahill, who's one of our advisory members for Fight CRC, is also for the Colorado Cancer Screening Program around the hereditary work that we do. And I think there's a lot of great gains in terms of talking about the implementation of what we know and what we can do. And then we're going to hear from Allie Bain from our American Cancer Society to really speak to how can we really implement that 45 to 50 recommendation through USPSTF and American Preventive Services guidelines. So one thing I want to just say as we get ready to go today is that the American Cancer Society did put out the recent facts and figures for colorectal cancer. And I think, we're seeing a little bit of a sort of slow but steady decline actually in screening it's saying steady, but we're not seeing the same trajectory of uptake that we once did. We're definitely for the younger population seeing more advanced cancers, more young people being diagnosed. And ultimately, even that 45 to 50 population that are eligible for average risk population in screening, we're only seeing about a 20% uptake. So all of that data is a little grim. I think we need to have some big wins. That's what this program is about. but also to remind us that we have made a lot of progress in breast, cervical, and colorectal cancer. Hereditary and lung, we still have a little ways to go, but I really am an advocate of thinking about whole person prevention and why we're really focusing on the preventable cancers today, the impact that I think that us and our team think that we can make, really working with all of you, especially for the medically underserved. So we'll go to the next slide really quick. We're going to have each one of our presenters talk a little bit further about their backgrounds and who they are. But here's a fun picture of everybody who's going to be joining us today. And again, with Erin and Nick, Heather, and Allie, we're excited because I think there's a breadth of knowledge at the local level, at the state level, at the national level. And we're just really super excited to have each one of these folks joining us today to share perspective, background, and really guiding the work that, again, I think keeps Colorado in the forefront as a leader in this area. But I also want to give a huge shout out to many of the navigators, primary care physicians, managers, CEO experts, all of our partners, because we couldn't do this without you. And I think we're making a huge impact. I do know today that Dr. Rich Schulich is giving a presentation about the impact of the Cancer Center's work, and we're one of the programs that he's featuring, even his lead outside. So we're really excited to be featured with that work. Also, Erin's going to be talking a little bit about the work with the Moonshot program, meeting at the White House, I believe, to a certain extent. And I have a chance to attend that. And we also have representation from Dr. Swati Patel, as well as some of our navigators all throughout the country who will be either integrated or in the discussion, like our AONN partners and others. So I'm going to turn it over to you, Erin, but I just want to say a huge thank you to all of you as we kick off March, a CRC Awareness Month. But also remember, when we're talking about preventive cancer screening, we really do need to be thinking whole person. So Miss Erin, you're up.
Hi, everyone. Happy March Colorectal Cancer Awareness Month. I'm Erin Darbuz. I'm the Health Policy Manager for Fight Colorectal Cancer. I have been with the organization for about 1.5 years, and it's been wonderful. My experience prior to joining Fight CRC, I worked on Capitol Hill for about 6 years for various members in several different roles, including legislative roles. So big background in federal policy. And while I worked on Capitol Hill, I actually lost my mother and my father, both to colorectal cancer, which got me into this space and got me to go back to school to get my master's in public health, so I could really focus on health policy specifically for cancer. And I just got so lucky that I got to do it for colorectal cancer specifically. Next slide. So Fight Colorectal Cancer is a national patient advocacy organization. We do lots of things, including patient support. We have research that we do, and a big part of our organization is policy. We're the only national colorectal cancer organization that does advocacy and policy change at the state and federal level. So we really are all over full circle in what we do and provide as far as resources, materials for patients, for clinicians, as well as driving that policy change. Next slide. So Fight CRC back right before COVID created what we have, our program, our Catalyst State by State Advocacy Program. So this program was really to hone in at the state level to find organizations that were already doing policy work in colorectal cancer. So rather than starting something new, someone with a foundation, it may be an ACS-CAN organization, it could be a state colorectal cancer roundtable, but folks that just needed a little extra push to get policy and legislation over the finish line. We focused on lowering the screening age to 45. This obviously started prior to the USPSTF lowering the age to get that codified at the state level, and then to remove patient cost sharing for follow-up colonoscopies. So what was happening was if someone took a non-invasive test and it came back abnormal, they needed that follow-up colonoscopy to confirm a diagnosis, and patients were being charged a lot of money for that because it was considered diagnostic. So at the state level, we helped to fund and give out grants to those organizations that were doing policy on these two issues, and we had quite a bit of success. You can go to the next slide. And we have our advisory council that we meet with to choose and select grantees to go over different policies, and as well as our strategic partners that help fund the grants that we disperse. Next slide. So this is a map of our state policy landscape, and you can see we've got about 12 different grantees, and 7 have already passed legislation through our program, with several others led with pending legislation. We recently just had some big wins in New York and New Jersey last month, so it's still moving along. So this is our map of our catalyst states and those that have been successful in passing at least one or both of the policy priorities that we talked about earlier. Next slide. So after USPSTF lowered the screening age to 45, we really honed in on this follow-up colonoscopy issue. We were hearing from a lot of our advocates, survivors, caregivers, that they are unable to have insurance coverage for that colonoscopy after they took a FIT test or Cologuard, any non-invasive test. And so we honed in on that follow-up colonoscopy. And this is sort of the map of how we got to where we got. So it all started with the Medicare loophole bill. I'm sure most of you know that bill was to remove cost sharing when a polyp was removed. So prior to this bill, if you had a colonoscopy and they removed a polyp, and you had Medicare, you could be charged for that removal. It took almost a decade to have that bill signed into law. From 2012, it was introduced, and it did not pass until 2020. In between that time, we did start this state-by-state legislation policy to codify at the state level. But finally, at the federal level in 2020, that loophole bill was signed. But I will say that we are still hearing from patients that are being charged, and this was, several years ago that this passed, but it's not been fully implemented across the board. Patients are still kind of dealing with that issue. Then Fight Colorectal Cancer, the American Gastroenterological Association and American Cancer Society Cancer Action Network reached out to the tri-agencies. So that is Health and Human Services, the Department of Treasury, and the Department of Labor. They kind of oversee commercial plans for insurance. And we reached out to them and said, you really need to put out guidance that a follow-up colonoscopy is screening. It's not diagnostic. Having an abnormal non-invasive test is not giving you a diagnosis. Screening is more than one test. It is a process. They agreed with us. And in January 2020, they issued that guidance in one of their FAQ notices, saying that commercial insurers must now cover follow-up colonoscopy. So that was great. We're excited. So we moved on to CMS and said, okay, Medicare, it's your turn now. So the same groups, American Gastroenterological Association, ACSCAN, and Fight CRC met with CMS after writing several letters and explained why screening is a process and why this is important to cover. And they put out their proposed rule, starting coverage at 45 and saying follow-up colonoscopy is screening. And then that final rule passed in November 2020 and was started implementing that rule on January 2023. So this is sort of the timeline of how we got to where we are. Next slide. So for follow-up colonoscopy, the commercial coverage is for all ACA compliant plans. This excludes any grandfathered plans that were admitted under the ACA and the traditional Medicaid population. The CMS coverage rule is for Medicare and the Medicaid expansion population. Of course, this is not helpful for uninsured folks, so we still need to do more work for those without insurance. But this is so you can see who's eligible for this removal of cost sharing. Next. So looking ahead, now that we have at the federal level removed follow-up colonoscopy for commercial and Medicare, for commercial plans and for Medicare, we really would like to expand the Centers for Disease Control Colorectal Cancer Control Program. Currently, it operates across 32 states among 35 different grantees. We are asking Congress to increase funding to $51 million to solely increase and expand to all 50 states. more than just expanding the program, we need to ensure that when you are diagnosed through the program, patients are able to access care, be navigated to care, and there's already successful models that are out there. So we're really looking at the Breast and Cervical Cancer Prevention and Treatment Act as a model so that those who are diagnosed through this program would be eligible to receive treatment through Medicaid once they are been diagnosed. So this is kind of what we're working on now and pushing at the federal level. Next. And implementation, it's so important. While our Catalyst grantees have passed at the state level these laws and it's done at the federal level, we still need states to continue trying to push at the state level because we just never know. The ACA could be repealed at any time. Things can happen at the federal level. So it's good to have it in the state laws as well, even if it seems duplicative at the moment. And we're looking at implementation. Like I said, we're still hearing about folks that are receiving bills when they have polyps removed. So we want to ensure that that does not happen for the follow-up colonoscopy issue. So currently we're working with the American Gastroenterological Association, and we're creating resources that we will be sending out to insurers, to physicians, and to patients. They'll be slightly different for each stakeholder group. However, it will talk about the changes when they went into effect because those commercial plans should have taken effect in May of 2022 and now Medicare January 2023, and that's not happening. So we're making sure that the physicians, the coders, billing departments are aware of the change, how they can best code for patients, what their rights are and what should be covered, what they should not be receiving bills for, and for the insurance companies that this now needs to be put into place if it's not already being given to their beneficiaries. So this is coming. Our payer pamphlet will be coming out this month, and we'll slowly be rolling out physicians and patients over the next few months. And you can all, of course, get access to that once we roll it out on our website, or we can mail you hard copies as well. Next slide. And that's it. If you have any questions, if you're interested in the Catalyst program, if you're interested in receiving any of our materials, please feel free to email me. I'd be happy to get you any of that, any questions that you have, happy to answer. And of course, you can always visit our website for more information on what we're doing in advocacy, as well as research and patient education. Thank you.
Excellent, Erin, thank you so much. I'm going to turn it over to Wesley and Elsa to help introduce our next folks. Erin, one of the things that you said, and I know one of the things that we've really struggled with in Colorado, as well as you've referenced all throughout, is really paying for those colonoscopies for people who fall outside of ACA and for that treatment. How would you say those conversations are going with CDC and others about maybe kind of a reciprocal CRC program? If that were to come to bear at some point, what does the timeline look like that?
So we have been in discussion with the CDC and they are all about it. They agree that that would be a great idea, and they truly would not want to expand to all 50 states without having navigation in place, because they don't want to diagnose people and then not be able to help them through, the full journey of their cancer treatment and diagnosis. So that is going to take an act of Congress to increase the funding levels enough in order to support and sustain that. So it is going to be policy driven. Unfortunately, in order to get like a treatment act put into place, we can't have an executive order for that. We do need Congress to pass that. So it all depends. It could take 1 year, it could take several. So we're really pushing and letting members, across the aisle, this is a bipartisan issue. This will not only save lives, but those who are concerned about the fiscal costs, in the end, this does save money to prevent cancer or to treat it earlier, to detect it, to save lives, to, people when they're diagnosed aren't able to work. So there's lots of ways that this is beneficial for everyone across both sides of the aisle. So we're hoping that it won't take too long, but it'll be probably at least a minimum of 2 years.
Right. Well, we'll hold you to it. We'll come back in 2 years and see where we're at, right?
Yeah.
Awesome. Thank you.
Great. Thank you so much, Erin. And we'll send out those slides, and then her email is attached for anyone who has any additional questions or follow-up for him. We'll send that in a follow-up email. But thank you so much. Next up, we have Nick Torres. He's the Director of Advocacy for the American Lung Association for Colorado, Utah, and Wyoming. And it looks like you got your slides up and ready to go. So I'll hand it over to Nick.
All right, great. Can you hear me okay?
Yes.
Excellent. I am so happy to be with you all. As Wesley mentioned, my name is Nick Torres. I am our newly minted advocacy director in Colorado. I have been with the Lung Association a little over 7 years, but until recently, it's about a year and a half ago, I was based in Indiana. And so I'm a new Coloradan, and really appreciate the opportunity to introduce myself and really introduce the work of the Lung Association here in Colorado. Really looking forward to expanding our advocacy work, our connection to patients, caregivers, and providers in the lung cancer and really any chronic lung disease space. And so it's my hope that you find me as a resource, and we can continue our partnership. So I'm really thrilled to be with you all. I'm also really happy to be with you, particularly for this call. This month is with so much focus on colorectal cancer. I lost my mother to colorectal cancer about 14 years ago. This year will be 14 years. So when I was working at the Ohio Capitol, so not the Capitol in DC, but the Ohio Capitol, I got my start in policy and advocacy work, and I lost my mother to colorectal cancer then. So, just like Erin's loss when she was on Capitol Hill, I felt that connection. So appreciate those personal connections, and I really love working with folks in this space. So I wanted to provide a little bit of an outline of what I'm going to cover today. I wanted to zoom in a little bit on one particular piece of legislation here at the state level, as well as talk a little bit about some of our efforts at the federal level in terms of advocacy, and talk about some new initiatives we have in the patient and caregiver network space that I hope you'll take advantage of. And finally, follow up with some advocacy opportunities that I hope you all might be interested in partnering with us on. So first of all, zooming into some local policy here in Colorado. House Bill 231110 is something that I think would affect a lot of us here in the cancer advocacy space. This would provide a mandate for coverage for biomarker testing and targeted therapies. Colorado would join one of several other states. I think there's 4 other states that have approved insurance coverage. But we know that for many types of cancer, biomarker testing is already standard of care. Not just cancers, in fact, but as I learned yesterday at the American Cancer Society's Cancer Action Network Advocacy Day, that many chronic diseases like arthritis also really take advantage of biomarker testing to provide targeted therapies for patients in that space as well. So the bill is working its way through the legislature here in Colorado. As I mentioned, it provides a requirement for that biomarker testing is covered by an individual's insurance, and that includes Medicaid. For us, focused on lung cancer, we know that Medicaid is about 25% of all Medicaid, 25% of lung cancer patients receive their care through Medicaid, and so it's an important population that we want to make sure is able to receive access to these life-saving treatments and targeted therapies without hurdles, without obstacles, and so the bill would make sure that that biomarker testing would be covered. And so it passed its first legislative hurdle in committee, 10-1, overwhelmingly supported, bipartisan, and it's now pending in the House Appropriations Committee. And so I really wanted to highlight this because one of the hurdles that the bill is facing is that each bill that that needs an appropriation, that needs funding from the state, it goes through a fiscal analysis. And here in Colorado, that fiscal analysis came back pretty, we would say, with a pretty high price tag, one that we hadn't really seen in other states. And so we're going back and reevaluating that and urging the fiscal office to take into account some other factors so that we can lower the price tag. Oftentimes, when lawmakers might look at a bill, at the bill's price tag and make a determination maybe not to move forward with that, especially in a year when there might be not as much funding to go around like this year. And so what I think is really important is to call on patients and providers to weigh in with their lawmakers to talk about the benefits, both potential and specific. If you or a loved one has benefited from biomarker testing, it's really important for us to lift up those stories with lawmakers to show that it's not just the immediate price tag of providing coverage, but rather that we would also see benefits and reduced cost of care and improved outcomes for patients. So telling that whole story, I think, is really important. So please stay tuned to that, and love to get you more involved in that. Zooming out to the federal level, the Lung Association is going to be taking part in our first in-person advocacy day since COVID. So we're really thrilled to bring out lung cancer patients and caregivers to Capitol Hill on March 29th. We'll be there all week, actually. And we'll be asking for increased funding for National Institutes of Health, Centers for Disease Control and Prevention, as well as supporting and protecting Medicaid. Those are our main asks. And so it's an incredible opportunity for us to bring out patients and caregivers from across the country to really show lawmakers in Congress what the story is in their states about lung cancer and how it's affecting folks in their state. We're also going to be providing some opportunities for folks back in the state to participate. So follow the Lung Association on social media, and I'll also make sure that we provide some follow-up details in this space as well. We call on folks back in the state who really understand this issue to make calls to Congress and really elevate the asks that we're making on Capitol Hill that day as well. Another initiative that the Lung Association is rolling out here, we're rebranding what was known as our Better Breathers Network and really expanding the benefits. And so I'd like to talk a little bit about our patient and caregiver network that we've just announced and relaunched this past week. So the patient and caregiver network provides an opportunity for patients and caregivers, loved ones, family members, advocates to plug into a nationwide network to receive special information about their chronic lung diseases, including lung cancer, of course, that might be helpful for folks who are looking for a place to go in a number of areas. So I'm going to talk about that in a little bit here. The network is providing peer support, education, and research. Those are our three main benefits. As I mentioned, we have 11 specific support communities online, but including lung cancer, as a place to go for folks to connect with other patients and caregivers. The education that's provided through the network includes some bi-monthly newsletters, as well as access to live and exclusive content through on-demand webinars focused on specific care for specific diseases, as well as ways to connect and provide a healthier network for folks to tap into. We also provide access to our clinical trials portal. Referrals to clinical trials is a major ask that we receive at the Lung Association. So we're also happy to provide access to those as well through the patient and caregiver network. So I just wanted to provide a quick overview of that, but I hope you'll seek out for more information for you and folks you serve, lung.org/PCN. Lots more to come on that as well. Finally, just to close, I wanted to provide an opportunity for advocacy. Oftentimes we receive requests from healthcare providers, loved ones, that they look for an opportunity to get involved in the big picture. And so I think these advocacy opportunities are important for us to keep in mind. We have, for example, right now, our health professionals in particular, we're asking to sign our petition as we urge the EPA to strengthen soot standards. Particle pollution is something that we deal with here, especially in the western part of the country, whether it's forest fires or transportation pollution. We know that the air quality is a major concern for those facing chronic lung diseases. And so we're asking the EPA to strengthen those standards for particle pollution. You can find the petition on our website at lung.org/strongerstandards, and I hope you'll keep that in mind as well. Finally, just wanted to offer myself as a resource. As I mentioned, I think it's so important for us to provide opportunities for patients to get involved and raise their voices. I think we've seen really positive outcomes for folks who connect with us and are able to connect with very specific advocacy opportunities. And so I would love to partner with you all again here in Colorado as I get to know you all and the amazing work that's happening with the cancer plans and screening efforts. I think we have enormous potential for a lot of good to come out. So again, appreciate your time and hope you'll reach out with any questions.
Hey, Nick, thank you so much. CCSP has really built a lot of our foundation on really cancer screening, cancer navigation, and the work out of the colorectal, really kind of formidable work that we did with the breast and cervical really informed our work in colorectal cancer. We've been really focusing on lung cancer and hereditary and really thinking about the workflow implementations and screening. And I'm glad that you mentioned at the end, really kind of thinking about the lung cancer screening aspect. Do you have a sense, I think, we're really thinking about how do we, as a leading cause of cancer death, and with what we've learned from colon, rectal, breast, how to really help move the dial for lung cancer screening. Do you see any sort of policy issues or anything that we could really get behind or keep kind of on our radar in terms of really thinking about how do we really look at implementation of screening and really kind of moving the needle, similar to what we've seen with breast and colon? Anything that you think we should have on, just to kind of keep the pulse on?
One thing I would say, not so much in the policy space, although I think it comes up in terms of storytelling. Any sort of policy that connects with lung cancer in particular, I think the more we can do to address stigma is something that I think comes up a lot in conversations with lawmakers, with policymakers, addressing the fact that if you have lungs, that you can get lung cancer, I think is something that I always go back to. But highlighting whether it's radon or it's particle pollution, frankly, air quality concerns, there are many other potential causes for lung cancer besides tobacco. And I think tobacco control is something that the Lung Association obviously cares deeply about, but not focusing the lung cancer screening conversation solely on tobacco and risk factors on tobacco, but talking about the needs for screening holistically.
Yeah, well, and one of the things that's come up, and I know Christy Cahill and the Cancer Coalition folks and Dr. Dyer and others, who I know, Nick, you work closely with, as well as Jamie Stutz, around the stigma issue. One of the things that we're seeing in rural frontier areas, as well as hospitals right now, is also seeing the steerage, which I didn't realize was a word, but really having insurance plans oftentimes denying screening within hospitals. And they're really trying to refer people to freestanding centers. But we know, oftentimes for especially low dose screening, that can be an issue because CT machines aren't oftentimes, especially in rural and frontier, there's not freestanding centers, it usually is a hospital-based setting. So that's something that I know the Cancer Coalition has on the radar, particularly it impacts lung screening, but it actually does impact that if referrals are only going to freestanding endoscopy centers or the like, it really brings hospitals out. Again, in rural and frontier communities, this is an issue, and also with capacity. So that's one thing I think we're also keeping track of from all the screening side. And then the one thing as we transition, I think, to Heather and Allie, where we're going to really be talking about some specific interventions around hereditary as well as colorectal cancer. And then Nick, I know that I'm so glad that you pointed out the biomarker legislation. And then part of the thing we've been working on with CCSP, the Alliance, others to share our data and stories. Also, everyone is really related to the community health worker bill, where we are in Colorado looking at that Medicaid reimbursement for community health workers and navigators. And so to Nick's point, I think several different bills have come in with some glaring fiscal notes, and that was one as well. But it did make it out of Senate and out of the committee with a unanimous vote, but it's also sitting in appropriations right now, hopefully for a little bit of a right sizing of what the fiscal note looks like. But between the implementation of what Erin spoke of, Nick, all the things that we have on the horizon, the opportunity, I know from CCSP, the Cancer Coalition, many of us are using our data as well as information that we have from our respective programs to educate. But Nick, I love that story of also advocacy, right? Like telling your story and being able to use that. And for many of you who are navigators, also sharing that impact in the community of what these programs do and how that's served, that's going to be a huge part of where we go. So Nick, thank you a ton. This has been great.
Yeah. Thank you.
All right. Wesley, I'll turn it back to you.
Awesome. Thank you so much, Nick. And just want to make a note, it looks like Christy Cahill with the Colorado Cancer Coalition put the email address in there if you want to join the conversation about cancer screening coverage in the hospital. I'll also include that in the follow-up email with all the information that we're sending out. But want to keep moving along so we can keep some questions for the end. Thank you, Andy, and thank you, Nick. So next up we have Heather Cahill. She is the Associate Director for the Division of Clinical Cancer Genomics with the City of Hope National Cancer Center. And she'll be talking about increasing the uptake of genetic counseling and testing for hereditary cancer syndromes. And I'll let her give a little bit more of an introduction for herself, but thank you, Heather.
Hi, everyone. It's great to be here today. Especially as everyone has noted on Colon Cancer Awareness Month. And I've had the pleasure of working with Andy in that capacity for many years. But I think out of that sort of collaboration, we started working together on this CCSP program to help people, particularly in primary care, FQHCs, to identify patients who might have a hereditary susceptibility to cancer and get them navigated over to cancer genetic services in the best way possible. And this has, of course, been challenging, I think, for everybody across the board, and more challenging, because of the lack of genetic counseling services that are available, which is something we're working on, and of course has been increasing with televideo options since the pandemic. So my talk will be a little bit different than everyone else's, because I am going to just give you a little bit of background on the two most common inherited cancer syndromes, because they're the basis for the tool that we created with CCSP, and they sort of explain why we think it's so important to identify individuals with these conditions. So obviously, the most important thing is identifying, out of all of the patients that you might work with on a day-to-day basis, who are the ones who are at high risk for getting cancer, because these individuals are going to need earlier and more frequent surveillance. They can't follow the general population guidelines. That's too little, too late for them. And so picking these people out from this crowd is really the challenge. And so far, the best modality that we have available to us is taking a family history. And taking a family history is really the key to doing accurate risk assessment and appropriate medical follow-up. And I'll just make a note here that we did some recent work looking at early onset colorectal cancer, where we found that if family history was taken in young adulthood and genetic testing was done appropriately for the patients who met criteria, and people followed surveillance guidelines based on their family history or their genetic test results, we could potentially prevent 16% of early onset colon cancer, which is pretty dramatic. And these are tools that are already available to us, but we're just not doing a very good job of implementing them. So taking a family history, we usually just take it at face value. If you see someone in genetics, we'll do a little additional work. So someone might report a family history here. This gentleman reported that his mom died of stomach cancer, his sister died with bone cancer, and his brother has prostate problems. But if we get path reports or death certificates, we might find out that mom really died of an ovarian cancer that was diagnosed early and she died at age 49. A lot of gynecologic cancers are confused with each other, called female cancers or stomach cancers. Kind of everything in the abdomen can get confused that way. Maybe his sister really had a breast cancer with bone metastases and he was remembering the bone metastases, and his brother with prostate problems might actually have a prostate cancer. And all of a sudden this family history that didn't look terribly alarming for hereditary cancer syndrome is meeting criteria for hereditary breast ovarian cancer syndrome. I think the other thing I do want to point out is just to keep in mind that family histories change over time. So a lot of people do a good job of getting a family history at their first visit for a patient, but not updating it every time the patient walks in the door, or at least annually. Here's a situation where this woman on her first visit said her mom had died of pancreatic cancer at 50, but 2 years later, her sister now has endometrial cancer and her brother's making colon polyps, and this is starting to look like it might be Lynch syndrome. So it's not a one and done thing with family history. It's something that we need to continuously update, because a family history that might not meet criteria 1 year might meet criteria the next. The most common hereditary cancer syndromes, as you all probably know right by now, are hereditary breast ovarian cancer syndrome caused by mutations in the BRCA1 and BRCA2 genes, and Lynch syndrome caused by mutations in a number of different mismatch repair genes. These are considered tier 1 diseases by the CDC, along with a non-cancer condition called familial hypercholesterolemia, which is a hereditary form of high cholesterol. These 3 conditions are considered tier 1 because they're common, they are easy to test for, and they're actionable. There's something we can do about it if someone tests positive for one of these conditions that can lead to a better outcome. And I think that's the key here of why we're trying to identify the patients who have these conditions early and intervene. An interesting study from Geisinger, and this has been repeated in the Healthy Nevada project, where they just tested healthy people from the general population, has actually found that 1 out of every 76 individuals in the general public has one of these 3 tier 1 conditions, which is unbelievably common, and really, when you stop to think about it, a public health problem. Because the other thing that we have shown in these studies is that at least 90 to 95% of people with these conditions are not currently aware of their diagnosis, so they're not able to benefit from the increased surveillance and prevention options. And I just want to point out that compare this to the positive rate for newborn screening programs. So every state in the United States has a newborn screening program where you get a heel stick of blood on all newborns, and they're tested for a panel of genetic conditions that can affect people in childhood. The positive rate on that is 1 in 800. And so I think that we really have to start thinking about a better way to get the general public tested for these 3 conditions in adulthood. And until we can do some sort of population testing, we have family history. So just a few words about hereditary breast ovarian cancer syndrome. We talked about the 2 genes. They were found in the mid-1990s. They cause increased risk for breast, ovarian, prostate, pancreatic cancer, and also melanoma with BRCA2. So significant increased risk for a number of cancers. And a lot of people think of these as female genes, and men don't have to worry about them, but men have many cancer risks associated with BRCA1 and 2, including potentially male breast cancer, prostate cancer, pancreatic cancer, and melanoma. And so it is just as important for men to be tested as women. And in fact, of course, men can pass this on to their children, some of whom may be daughters who have the very, very high risks for female breast and ovarian cancer. Now, the reason identifying patients who are eligible for genetic counseling and testing is difficult is because the NCCN guidelines are complicated, and they change at least once a year. So this is the current version for breast cancer. And I mean, I don't blame anyone for not being able to keep track of these and follow who gets testing and who doesn't. And then here we have for ovarian cancer, pancreatic cancer, prostate cancer. So what we've done at the end, you'll see, is distill these down into a small set of criteria that don't encompass every single one of the NCCN guidelines, but encompass the main largest ones and are easier to use and apply. And of course, the reason we do this is because there's very specific and very different management for these individuals that can really save their lives. So women with hereditary breast ovarian cancer syndrome, for example, start annual breast MRIs at age 25, and at age 30, they add on an annual mammogram, which they usually alternate 6 months apart. Very different from the screening in the general population with annual mammography starting at 40. And of course, there's consideration of risk-reducing mastectomy at this level of risk too. For ovarian cancer, because there is no effective screening test, it is actually recommended that when done with childbearing, women with BRCA mutations consider removing both of their ovaries and fallopian tubes to keep from getting ovarian cancer. Men do have increased screening, and in fact, men who have gynecomastia even do have a mammogram recommendation. Prostate cancer screening recommended for BRCA2 mutation carriers and consideration for BRCA1 mutation carriers. And for both men and women, melanoma screening guidelines, annual full body skin exam, and pancreatic cancer screening is actually recommended if they have a close relative who has pancreatic cancer, including endoscopic ultrasound and MRI or MRCP. Annually, starting around age 50 or 10 years younger than the earliest age in the family. So very different screening guidelines for these patients that hopefully will prevent cancer or catch it early when they're treatable. This also can affect a patient's treatment. And so we now treat breast and ovarian and prostate and pancreatic cancers differently if we know they're being driven by a BRCA mutation. And this has been really kind of paradigm shifting, that we can treat the underlying mutation and get better outcomes with less side effects. And so PARP inhibitors have shown really great promise in people who have both inherited BRCA mutations and acquired BRCA mutations, which is one of the reasons, like Nick said, we need to be able to do biomarker testing in tumors. We need to do germline testing to look for the inherited BRCA mutations, but we actually have to do tumor testing to see if people have acquired BRCA mutations that are not inherited, because in either case, the patient might benefit from a PARP inhibitor. And just testing has just gotten so much better. Since 2013, we've been able to do these multi-gene panel tests. The out-of-pocket maximum for these tests, which have sometimes over 100 different genes in them, are $250. And many of you on this call will remember the days when we could just do BRCA1 and 2 alone for over $4,000. So this has really changed access dramatically, and makes it much easier to make sure that our patients who meet criteria can get the testing that they need when appropriate. In addition to the $250 out-of-pocket max, there's excellent financial hardship programs, and anyone who makes less than 4 times the federal poverty limit generally will get their testing covered for free. But looking at 35,000 breast cancer patients tested with a panel of 25 genes, 9.3% did test positive for a pathogenic variant in a cancer susceptibility gene. About half were in BRCA1 or 2, so that is the most common cause of breast cancer, but the other half were in other genes, including CHEK2, ATM, and PALB2, which are considered more moderate risk breast cancer genes. If you're younger at diagnosis, you're more likely to test positive. An old study of 360 ovarian cancer patients who had a multi-gene panel show that ovarian cancer patients have really the highest likelihood to test positive of almost any cancer. And so this is what's led to the recommendation that every single patient with an epithelial ovarian cancer or a fallopian tube primary or a primary peritoneal cancer be offered gene testing regardless of age of diagnosis or family history. 24% tested positive for one of these panels, one of the genes on the panel. 18%, so the vast majority were BRCA1 and 2, but the other 6%, as you can see here, were just sort of a variety of other cancer susceptibility genes. Sorry, the slides keep spinning. My mouse is going crazy today. Switching to Lynch syndrome, which is my personal area of interest and research interest. This is the most common inherited form of colorectal and endometrial cancer. And here are the 4 main genes that cause Lynch syndrome pointed out here. These were also found in the 90s, but testing for these 4 genes took a lot longer than BRCA1 and 2. 1 out of every 279 individuals has Lynch syndrome. So that means there's over 1.2 million people in the US today with Lynch syndrome. And again, high risk for cancers that are really potentially preventable with earlier and more frequent screening. So the problem is that 95% of these people are not aware of their diagnosis. The cancer risks vary depending on which gene is causing it, from anywhere from 9 to 10% lifetime risk for colon cancer with the lower risk Lynch syndrome genes, up to as high as 61% for the higher risk colon cancer genes. And here you'll see the endometrial cancer risk is significantly elevated as well. There's also increased risk for stomach cancers you see here, ovarian cancer, urothelial cancers, hepatobiliary cancers, pancreatic cancer, brain tumors, and specific skin cancers of the sweat gland. But the main two cancers that we worry about are colorectal and endometrial. Again, very complicated set of criteria that change frequently, making it a little difficult for providers to know, when do I need to refer this patient? Definitely different management guidelines. People with Lynch syndrome due to the two high-risk genes start colonoscopy every 1 to 2 years at age 20 to 25. People with the lower risk Lynch syndrome genes start at 30 to 35 and repeat every 1 to 3 years. But just think about this. If you have Lynch syndrome and start colonoscopies at age 20 due to one of the high-risk mutations and get them annually, you might have had 55 colonoscopies by age 75, when someone in the general population might have had 3 or 4 by that time. So this is a very different management, and obviously not something you want to do unless you need to do it. But identifying these patients is critical to getting their cancers removed as polyps and keeping them from getting cancer in the first place. For endometrial cancer, it tends to get diagnosed early and have a good outcome. But because there is also an increased risk for ovarian cancer, which we don't have good screening for, many women with Lynch syndrome elect to have risk-reducing hysterectomy and bilateral salpingo-oophorectomy, or removal of the ovaries and fallopian tubes, after childbearing. And increased risks for their screening for some of the other cancers associated with Lynch syndrome as well, including EGD to look for stomach cancers. Then depending on family history, screening for pancreatic, urothelial, and some of the other cancers here, as you see here. Lynch syndrome is special in that it does have several genetic features, which also are included in biomarker testing, like microsatellite instability, which has become very, very important since the advent of immune checkpoint blockade therapy in 2015, which works remarkably well in MSI high tumors. It also turns out I'd been trying for 20 years to get this done for all colon and endometrial cancer patients because it determines a group of patients who are more likely to have Lynch syndrome. Most hospitals don't actually do MSI testing. They do something called immunohistochemistry staining instead. This is a picture of that on the screen, and they actually just cut 4 slices of the tumor, stain it with an antibody that attaches to the 4 mismatch repair proteins. If you see brown nuclear staining like you do here and here, the protein is present. If you don't see brown nuclear staining like you don't here and here, that means the protein is not being produced, which tells you it's not working for some reason, either an inherited mutation or an acquired mutation, but something is causing that not to work properly. Those tumors are by definition microsatellite unstable, and the patient is more likely to have Lynch syndrome and needs to see genetics. And obviously is a candidate for immune checkpoint blockade therapy too. So there are now many, many recommendations saying that every colon and every endometrial cancer patient should have tumor screening with either MSI or that IHC test at the time of diagnosis. Unfortunately, it is not being done at every hospital. And so anything we can all do to affect policy, people are working on a Medicare MIPS measure. There's work on a HEDIS measure. Andy and I have been trying to get a COC accreditation standard. Anything we could do to help promote universal tumor screening for Lynch syndrome is going to help not only identify patients with Lynch syndrome, but also identify patients who can benefit from immune checkpoint therapy. NCCN actually recommends this could be done on all GI cancers, endometrial cancer, urothelial, and sebaceous skin cancers, because those are all Lynch syndrome associated cancers. And interestingly, if you find this on accident in tumor testing, say you're doing tumor testing on a lung cancer and you find microsatellite instability, only 2% of all cancers have microsatellite instability when you test all comers. Of course, it's higher in colon, 15%, and endometrial, 30%, but across all tumor types, it's 2%. But 16% of those with a microsatellite unstable tumor do have Lynch syndrome, even if it's not a tumor that's traditionally associated with Lynch syndrome. So I think it's important for people who work in other organ groups to remind their providers that, they get excited when they see MSI because they know they can use an immune checkpoint blockade inhibitor, but they need to also think, this patient's more likely to have Lynch syndrome and we need to refer them to genetics. And here's the data on the very first study showing that the immunotherapy worked well in MSI high colon cancers, where there were 4 partial responses and 5 stable diseases. Didn't work as well in proficient colon cancer, and also worked in endometrial, prostate, other cancers that were MSI high, with 1 complete response, 4 partial responses as well. So there have been many, many studies since then, including the really exciting data from Memorial Sloan Kettering last year on rectal cancers, showing that MSI high rectal cancers may be able to be treated with immunotherapy and not even have surgery or chemotherapy. Another panel study, just to give you a sense, if you test all comers with colorectal cancer, here's a study looking at 1,000 of them with 25 gene panel, about 10% test positive. 3% have Lynch syndrome, so that is the most common inherited form of colon cancer, but the other 7% just have mutations in a variety of other cancer susceptibility genes, some of which may not even cause colon cancer, but certainly is still helpful for that patient to know about for their future cancer risks and for their family members. So how are we incorporating this all into CCSP? So we are providing technical assistance to clinic systems for using screening tools to identify individuals in need of genetic counseling and testing, and to get them connected with genetic services based on risk. We're doing that in 2 ways now. One is being facilitated through the Ambryogenetics Care platform, which is a really exciting platform where they can integrate with your scheduling system and send a text message or email to all upcoming patients, requesting that they provide their family history information into an app. It is like a chat bot, so they feel like they're texting someone, but it's a secure website where they enter their family history information. And here's the real benefit. They have programmed the most current NCCN guidelines and update it every time the NCCN guidelines get modified. So you never have to worry about memorizing those criteria that we flipped through earlier. It knows them, and it will let you know if your patient meets the criteria. You can refer them locally for genetic counseling and testing in that case, or you can refer them through the program for testing and counseling as well. So this is a newer thing that we've been working on through CCSP, but we also from the start worked on a more low-tech way of identifying patients, which is a manual family history screening tool. And I will just show you that. So basically, as I mentioned, they're based on the NCCN guidelines that we reviewed for hereditary breast, ovarian, pancreatic cancer, and colon cancer. It does not include every single guideline because then it would be too complicated to use, but it's been distilled into an easy use set. And this is going to identify patients who could benefit from cancer risk assessment with a genetic counselor. And when they see us, we can tell them what's their risk for getting cancer and what's the likelihood that their family history of cancer is hereditary. If that's high, we can help them get genetic testing if they're interested. And it will change if it will change their management. And so keep in mind, there are patients who may not meet these criteria who still could benefit from cancer risk assessment if they're very concerned about their family history, if they're adopted and don't know their family history, or if one side of their family is small or they're estranged and they don't have that information. And this is just a screening tool. It is certainly not going to identify everyone with a hereditary cancer syndrome, and it's to be used in conjunction with provider input. But here it is. And so you can see this is much easier and more succinct than the NCCN guidelines. And it's boiled down to a series of yes or no items. And what you're asking is whether the patient themselves or one of their close relatives, and when I say close relatives, we mean first or second degree relatives. That includes parents, siblings, children. Those are first degree relatives. 2 steps away, we have half siblings, aunts, uncles, grandparents, and grandchildren. And so those are the relatives you're asking about here. And if any of those if they say yes to any of these prompts, then they would warrant referral for cancer genetic evaluation. So breast cancer diagnosed at 45 or younger, and this may be going up to 50 in the new NCCN guidelines. Ovarian cancer diagnosed at 35 or older. And I will say this age criteria is not in NCCN, but when we were using this criteria, cervical cancer was getting confused for ovarian a lot. And we were getting told all these people had ovarian cancer at 22, they were actually cervical cancers. And so by adding this age criteria where you had to be older than 35, it's actually helped us to get more accurate ovarian cancers. Male breast cancer at any age, colorectal cancer at any age. This is added this year. It used to be under 50. Now you can consider a multi-gene panel test for anybody with colon cancer. Endometrial cancer at 35 through 49. Again, this was supposed to be under 50, but because of that confusion with cervical cancer in the early 20s, we had to provide a different age guideline to make this work better in practice. Pancreatic cancer at any age, prostate cancer that's metastatic, so spread outside the prostate at any age, and then 3 relatives with breast cancer on the same side of the family at any age. Again, when you start to get multiple cases, you're more likely. 3 relatives with any of the Lynch syndrome associated cancers on the same side of the family. And then Jewish ancestry and breast cancer at any age, because Jewish individuals are more likely to have hereditary breast ovarian cancer. So this is a fairly easy tool to kind of whip through with the patients or have them fill out themselves. And any yeses warrant referral to cancer genetics. And the implementation process is that CCSP provides support, technical assistance, and training for clinic systems to develop and implement a workflow to administer the family history tool on a population-based approach, utilizing patient navigators. If the responses to either the Ambry tool, which is the more automated high-tech version, or the paper family history screening tool are reviewed by the provider, patients who said yes are referred to genetic counseling and testing. The navigator works with the patient to identify and address barriers to care, and the genetic counselor will provide screening and medical management recommendations to the patient and primary care team based on the genetic testing results and the risk assessment. And I couldn't leave without one policy thing. So just so that you know, genetic counselors are actually not currently recognized Medicare or CMS providers. What that means is that if a Medicare patient is referred to see a genetic counselor for genetic counseling, which they actually recommend, which is kind of hypocritical for, basically all ovarian, all pancreatic, all metastatic prostate cancers, all colon cancers, like we were just talking about, many of whom are on Medicare, if they get referred for genetic counseling as they're supposed to, Medicare will not pay for the genetic counseling if it's provided by a genetic counselor, which is really just silly. So this is actually in the Closing the Gaps on Care President's Report from Moonshot last February, that genetic counselors should become CMS recognized providers. It's the only recommendation that requires legislative action. We have had a bill introduced into several sessions of Congress unsuccessfully. It will be reintroduced sometime in the next month or two to the House and the Senate. We had done pretty well in the last cycle. We had 68 co-sponsors in the House and I think 9 in the Senate. And just Fight CRC has just been an amazing partner, helping us kind of navigate the system. I wish we were quite as successful as you have been in getting some of the bills passed, but this one I think will benefit a lot of cancer patients. So anything anybody can do to help out would be appreciated. Thank you.
Well, Heather, you beat me to the punch. I was going to ask you, let's talk about what are the most pivotal legislation, and there it is.
I knew when Erin spoke, I said, oh, I've got to talk about my policy issue.
I know, exactly. But it's a huge issue because I know it really impacts so many of our programs. So this is fantastic because I think today we really thought about for the colorectal, for lung, for hereditary cancers, like what were the big wins and what were the things that we really needed to elucidate. And I think you've done that beautifully. Heather, this is your 3rd presentation back to back today, correct?
Yes, March is busy for all of us, I'm sure.
Right. And you also send a tweet a day, right?
Yes. And I'm behind on today's tweet. Yes.
Okay. Well, good.
I'll get it out though.
Yeah. A huge thank you for all of the work that you're doing. Heather's a national expert, advises on the work we do at the state level. We work together nationally as well. And then Heather, I just want to also remind folks that ultimately that Ambryogenetics tool is something that we have, Heather helped broker a relationship with Ambry through the University of Colorado Cancer Center. We do have a contract. And if you are a CCSP partner or affiliate, we can work with you on really basically free of charge, implementing that through your systems. And that's something that we have available. We have a handful of sites and systems that are using that. But I just want to also reiterate that if you want to talk about actionable items that can really come from what Heather spoke of today, that's really it. But Heather, thank you a million, because without those connections and without your leadership, we really wouldn't have a number of those opportunities available. So thank you so much for all of your work.
Thank you.
Great. Wesley?
Awesome. Thank you so much, Heather. For our last presenter now, we have Ali Bain. She's the Associate Director of State Partnerships with the American Cancer Society. Looks like she's got her slides up. And then after her presentation, we'll have about 5 minutes at the end for Q&A for Ali, for Q&A for everyone else who's been here. So yeah, I'll send it over to Ali now. Thank you.
Thanks, Wesley. Good afternoon, everyone. I need to start off with that I thought Andy was going to mention at the start of this webinar is that we all should congratulate CCSP on being one of the national awardees from the National Colorectal Roundtable this year for 80% in every community. So big kudos to them. We all know that they do awesome work, but it's exciting to see them recognized. So congratulations to the CCSP team. So I am also going to be kind of pivoting from what Heather was just talking about and bringing us back to previous changes in policy that Erin talked about with the USPSTF lowering their guidelines to 45 for colorectal cancer screening, and just some kind of thoughts and resources and information about what we need to do to make sure that we are increasing screening in this age group. So as Wesley mentioned, I do work for the American Cancer Society, and our goal is to end cancer as we know it for everyone. And we do that 3 different ways: through patient support, which is kind of our focus of today, our Cancer Action Network, which has been mentioned a couple times, and our policy work, and then of course our extensive research pillar. So Andy mentioned this a little bit kind of at the top of the call. So just at the beginning of this month, the American Cancer Society released our latest colorectal cancer facts and figures. And it was some pretty startling data. So just to show a little bit graphically and a little bit more specifically to what Andy was alluding to earlier, you know, we are really seeing an increase in incidence and an increase in mortality for folks that are in the 20 to 49 age group, while we are seeing in the 50 to 64 age group really a leveling off in diagnosis and even a decrease in mortality. So not only do we need to be screening these folks, but we know that they are being diagnosed with colorectal cancer. There's ongoing research to figure out, you know, why this is happening, but I think this is a good take-home message to us in the clinics and that are working with clinics that, you know, this is an important age group that we really need to be addressing this. So just a couple other little tidbits around the 45 to 49 that Andy also mentioned. So ACS has recommended starting at 45 since 2018, and then just recently the USPSTF agreed. And so whenever we look at this age group with 45 and over, we see that about 59% of folks are getting screened, which doesn't seem terrible, but also knowing that our goal is 80%, But whenever we dive a little bit deeper, we see in that 45 to 49 age group that only about 20% of folks are getting screened. So when we think about the typical disparities that we address, whether that's related to race or ethnicity or geography, or even folks that are uninsured, this 20% screening rate is really falling right down there with our uninsured folks. So, what can we do to really work to increase colorectal cancer screening for 45 to 49 and get that up a lot higher than 20%? So as all of you guys know, and I've even shared on previous CCSP meetings, there are specific strategies that we all know that we should be using for increasing colorectal cancer screening. So whether that be doing client reminders or patient navigation, having prompts on our EHR. So the strategies don't really change for this age group, but we just need to think about how we are specifically tailoring them for this age group, much like we would for other underserved populations that we work with. So ACS has recently updated our steps for increasing colorectal cancer screening for primary care. So this guide is available. It focuses on different strategies, kind of the different steps that you should be taking to increase screening in your practice, and is a really great tool. So I'll share a link to that at the end. So whenever we're thinking about what should we be doing to really tailor our messaging and our communication for specific populations, this is a guidebook that we frequently will reference. So this came out in 2019, so shortly after ACS lowered our guideline recommendation to 45. But the cool thing about this guidebook is that it really looks at specific populations that are unscreened and what we can do to motivate them, what are certain demographic information about them that we should be thinking about, and then what do those messages really look like. So whenever we look at 45 to 49-year-olds, it's certainly a much different population than when we're looking at our 65 plus Medicare population. So we see that education is higher. A lot of 45 to 49-year-olds are married or living with a partner, and 70% have children. So when you're thinking about getting a colonoscopy, that's much different whenever you're working, have children. Those variables are things that we need to take into account when we're thinking about, what is that best test and how can we really get these folks screened. And then we also see how lifestyle and behaviors are really playing into this. So we see that only 56% of folks in this 45 to 49-year-old age range are going to the doctor. So thinking about that people consider themselves healthy, that they exercise, that they don't need to worry about screening because they're not old enough. And so whenever we're developing our messages and thinking about how to reach these folks, we need to create some unique strategies here. So whenever we asked, as a part of this, putting this information together, what the barriers to screening were, the doctor didn't recommend it, I'm not old enough, I don't have symptoms, or just procrastination, I'm busy, I'm taking care of my family, I'm working, I don't have time. And so again, just thinking about all of these different components and information about this age group that we need to address differently than maybe we have historically when talking about colorectal cancer screening. So this is kind of the messaging part that I mentioned about this within this guidebook. So within the research that was performed to put all of this together, the baseline screening rate for this 45 to 49-year-old age range was 9.7%. And so we saw through using these different messages that the screening rates really jumped up. So the first message talks about that colonoscopy isn't your only option. So again, thinking about what might be a more simple test for a patient, what is something that will disrupt their life a lot less than trying to do colonoscopy prep while trying to work and take care of your family. Knowing that for number 2, that saying like, you might not have symptoms, but that doesn't mean that there still might not be something happening there. So, you know, if we do this screening, we could remove this precancerous polyp and you're kind of good to go. So thinking about different ways to message that as well. And then for number 3, thinking about preventative care. So, you know, you can think about people that need to take care of their families. And so thinking about different ways that we can prevent colorectal cancer before it becomes cancer. And then communication preferences is another thing that is mentioned in here that I thought that I would just highlight. So preferred channels for delivery is the primary preferred channel was discussions with the doctor. So whenever you do have folks in this age group in your clinics, making sure that you're taking advantage of that visit and really talking about everything. And then also knowing that 45 to 49-year-olds may be a little more tech savvy than some of our 65 plus folks that we're talking about screening with. So thinking about different ways that we can engage them through our websites, through our online patient portals. You know, can you just request a FIT test or a Cologuard test rather than having to come into the doctor? So thinking about different ways that we can prompt folks using technology too, I think is really important with this age group. So as always, ACS has some patient education materials that can really help with the delivery of these messages. So we do have this decision-making aid tool that can be used to help with some of these conversations. And so on the right side here, you can see that there's a little like bubble ACT test kind of situation going on here that just asks some different questions about, you know, do you want to collect your own stool? Do you want to do this every single year? Is completing the prep something that you have concerns about? What about an invasive procedure and taking time off work? You know, are these things that you can do? And then thinking about folks that need a ride. So we know that transportation is a huge barrier for lots of people, but it certainly could be for this age group too, if you're in a household where both partners are working. So just some things to consider. And then also just some general kind of myths that you know, we have to talk about a lot with patients too. So a little bit of a one-stop shop here as far as information about colorectal screening and how to help really have that conversation with patients. Additionally, knowing that this is an age group that multiple tests and sharing information about multiple tests seems like it would be a pretty good strategy. We do have these flyers that do talk about it talks about all of the screening types that are recommended, but for these purposes, I just included colonoscopy, FIT, and FIT DNA. So this talks about the different pros and cons of each test, and that could probably help to answer some of those questions that folks might have too. Here's the FIT test that again just talks about you don't have to take time off work, but also that if it is positive, you do need to have a colonoscopy. And then finally, the stool DNA or Cologuard, knowing that if you watch TV, you know that people are being inundated with Cologuard ads, which is great, but also making sure that you're having the conversation about whether or not this is the right test. And that is it for me. So I'll put some links in the chat and my email address. So if you're interested in any of these resources, just let me know and we can get you connected to them.
You know, Allie, as soon as you said something about Cologuard, I don't know if anyone saw or heard of Woody Harrelson on Saturday Night Live, but Cologuard is even attacking Saturday Night Live in March. So that's fantastic that we're taking this more mainstream. Allie, but I think really around the area of implementation of, you know, all the different resources and support, if folks, I know you mentioned several of them, actually a lot of them, are most of these available on the website? Like if people want to do bulk order, what's your recommendation for folks?
So the easiest way is really just to reach out directly to me. So if you have the capabilities to print, we can send you just the PDF and you can print them on your own. If you would like us to print them for you, we can also do that, and then we can just mail them to you. So a few different options there, but certainly the easiest way is to reach out to me, or some of the resources are on the NCCRT website too.
Awesome.
All right, thank you so much, Allie. Just a plug for what will tie in nicely to what Allie spoke about with the techniques for communication for 45 to 49-year-olds is that we're also hosting a discussion on April 18th with Dr. Whitney Jones to go into and complement more of the communication and messaging strategies for this age group. So I think that'll be really interesting for people who would like to join. It's been in some of the same outreach that we've done around this event. So yeah, thank you so much. We do have a few more minutes here at the end for general questions and Q&A, either for Allie or for any of the other speakers. I hadn't seen any come up in the chat, but if anyone has any questions or comments, now's the time. And then before I forget, when you click out of the meeting today, there will be a link that sends you to an evaluation. Just make sure to fill that out. It should be pretty brief and pretty straightforward, but we asked that just so we can learn what went well and improve upon for future webinars and trainings. So with that being said, does anyone have any questions? I have a question for Heather around family history and getting information out of relatives. Do you have recommendations for those kinds of tips? What if we cannot get a full family history? What does that conversation kind of look like? I'm just thinking about conversations that I've had recently where I learned a stomach cancer was actually a pancreatic cancer, and that kind of changed. So it was like your slide. So
yeah, no, it's so common. It's so common, Wesley, and it's a challenge. I always say, you know, to try and talk to people about it when you've got a lot of people together over the holidays, because sometimes crowdsourcing the information can help, because maybe your mom or dad thought your aunt or uncle or grandparent died of one kind of cancer, but your cousins who belong to that aunt or uncle may have more information or more accurate information. I think death certificates are actually publicly available. And so the older generation was that generation where it's tough because people didn't say the C word, didn't like to talk about cancer. And so those can be challenging for anyone to figure out. And so sometimes the easiest way to get those is to actually request a death certificate. Older death certificates really were quite good at listing causes of death and contributory causes of death and how long the person has had that condition. So you can kind of even figure out not only the age of death, but when they were diagnosed with the cancer. I've found some of those to be very helpful. And then, you know, if you know a little bit about cancer, sometimes when I get female cancer, I'll ask a little bit about, well, do you know how it was detected, right? Because if it was a Pap test, it's probably cervical. If it was, she looked 6 months pregnant, it was intense treatment, died shortly thereafter, more likely an ovarian. Heavy bleeding might be more of a sign of endometrial with a good prognosis. And so knowing a little bit about how the cancers are diagnosed and treated can sort of help you too to get hints. Those are tricks I'll use with families when they're not sure. And then lastly, it's fine if you don't know. I take a lot of pedigrees where someone says she died of cancer, but I just don't know what kind. And we just write it down as cancer site unspecified, and kind of, you can then look at the risk assessment sort of worst case scenario. What if that was a pancreatic cancer, for example, or maybe it was a non-melanoma skin cancer and it's not contributing at all, but you can give kind of a range of risk. Now that the testing is so much less expensive, we don't have to be as precise as we used to, and we aren't looking for people with the very highest likelihood of testing positive because it was, such an investment back then. You only wanted to test people with a really high chance of testing positive. Now that it's more accessible and affordable, we can be a lot more flexible about testing people who just, may not have any idea what their family history is, but this could be important for their health.
Awesome. Thank you.
Heather, let me ask you something, and this is probably going to put you on the spot a little bit, but that's what I'm here for. But okay, if you're a navigator and you were working at an FQHC or a rural health center or critical access hospital, and let's say there's so many competing demands, hypothetically, right? Just hypothetically that this is the case. And really, maybe you're not in a place to implement the CCSP tool, and the Ambryogenetics is like you're hoping to be there at some point, you can implement. But if you can do one thing and you're within this group, you're working on the breast and cervical cancer screening program, you're working on our screening program. But if there's just one thing that's low tech, easy to do, just to even start to put your toe in the water around genetic and hereditary, with your team, what would be the one thing you would recommend?
Well, it's hard to pick one, and the tool is something you could give the patient in the waiting room, and so you just have to look and see if they said yes to anything. And so I like to think that it's might not disrupt clinic. I do know this is hard. Primary care physicians have 3 minutes on average with a patient, and talking about a 3 generation pedigree and every health condition they might be at hereditary risk for is more, not as much time as they have. So I think these automated options or these short questionnaires that can be done before the appointment or in the waiting room or at home are really a big solution for not jamming up the clinic. But if you weren't going to do any of that, I think if you're working with the Breast and Cervical Cancer Project, things to know are single ovarian cancer patients get referred, young breast cancer patients get referred. And at this point, basically every colon cancer patient gets referred, and young endometrial cancer patients. So I would kind of like distill it down to those things, and just so that you don't have to memorize a lot of stuff, but oh yeah, her mom had ovarian, she needs referred. She's got breast at 40, she needs referred. Like, I just distill it down to the simplest set that you don't have to look up, and at least refer those patients.
Awesome. Thank you. That's a great recommendation.
We have 2 more minutes. Any other questions? Right. Well, if we think of any other questions, or if you think of any other questions, the contact info for the speakers will be in the follow-up email that I give. We'll have a link to this recording on the website, as well as any of the slides that have been shared. I'll make sure to get the links that were put in the chat into this follow-up. And yeah, it looks like we're done for the day. Once again, thank you all so much for joining. All the great work that you're doing here in March. I know that everyone has probably more meetings and presentations and things to do this month, so we really appreciate you all taking the time to join us, and I'll go ahead and end it for today. Once again, a lovely thank you to all of our speakers. Yeah, it was very informational, and really appreciate. Awesome. Have a
Thank
good
you,
day, everyone.
everybody.
Thank you.